Good afternoon, everyone. Dr. Veena has put up a really convincing argument against indiscriminate use of autoantibodies. That was a really great talk. So I'm going to try to do my bit. Before I begin, at the outset, I would like to thank Chandrasekhar sir for giving me this opportunity. This API Bhavan has been a place that I've been coming to consistently for more than a decade. I've presented cases over here as a postgraduate, as a fellow. This is the first time I'm coming as a consultant. So that's more like a full circle moment for me. Coming back to the presentation, the topic was test for autoantibodies. Are they required in all patients with joint pain, skin rash, and other features? Before we talk about antibodies, let's have a little break. We've been talking about ANA since morning. Now, I'm just going to take you to some holiday destinations. Christmas holidays are around. So your first destination is Serene Beach, somewhere in Australia. What all would you take to go to the beach? A swimsuit, probably a hat, and some sunscreen, and you're sorted. Next, if you want to go to some Amazon rainforest, you need waterproof boots, insect repellent, flashlight, and first aid kit if you have some personal medicines, and of course a rain jacket, never to forget that, and warmers in case you might feel cold. Or if you're into trekking and hiking, if you want to climb this mountain, you need to be really geared, as in you need layers of clothing, thermals, fleece, double insulated snow jackets, warm caps, trekking poles, ropes, and whatnot. Fire starters, maybe matchboxes, lighters, tent gear. You need to carry quite a lot of stuff. So you can pick and choose your holiday destination. With that, I wish you all a very happy holidays. Let's just move back to the autoantibody testing. So autoantibody testing is more like a compass in the maze of a multi-system involvement. We've all discussed quite a lot about it. I'm just going to summarize about what we spoke since morning. Why primary care physicians are the first gatekeepers of connective tissue diseases. Almost 80% of patients first present to primary care. Unless a primary care physician can pick it up, it is very unlikely that that person will get diagnosed properly and treated properly. Second, early autoimmune features are very non-specific and are very easily missed. Also, if you are equipped with the knowledge enough, I hope that you've had enough of information and clarity of thought to decide when you should be testing autoantibodies or not throughout the day. If you can refer early, depending on early suspicion, often it is guided by autoantibodies. Now, why do autoantibodies matter? They detect disease before organ damage becomes obvious. Dr. Renuka made my job a little easier by mentioning that anti-CCP comes in your blood before you have symptoms of RA. Do you need to screen everybody with an executive health package arthritis panel? No. But if you have the information, you would keep the patient on follow-up regularly. And they act as biological signatures of evolving CTDs. Autoantibodies provide objective evidence in ambiguous presentations. When you cannot decide as to which clinical picture it is proving to be and you're doubtful of something and you think it could be lupus and you test for it, if you have an anti-Smith or anti-dsDNA, then you do have a diagnosis, even though the patient does not have full-blown symptoms yet. And guiding primary care physicians to rheumatology referrals whenever it is positive. So there is quite a lot of evidence in literature regarding evidence of diagnostic delay in all CTDs. The average diagnosis delay in SLE is a whopping 47 months. It's 4 years. Do you want to put someone through so many symptoms, create enough damage so that when you send to a rheumatologist, the organ system is already fried and you cannot do anything? Do you want to live with such a regret? Definitely not. Moving on to Sjogren's, it is even more higher. Sjogren's, like we said, it's just dry eyes, dry mouth. Nobody really reports it. Some patients think that there is some dust in the eye and they might not even get tested. So it takes about 5 to 7 years for it to even come into the picture. Myositis is very often diagnosed late because of not significant weakness. How many of us do regular hikes, treks, or exercise to identify your muscle is weak? You barely sit on the floor. I don't think anybody sits on the floor unless it is required for a religious purpose or something of sorts. So you don't know if there is a proximal muscle weakness, which is actually the first symptom that happens in myositis. So again, quite delayed. Scleroderma, failure to test or misinterpretation can lead to delay in recognition of early or limited forms. So these delays lead to irreversible organ involvement. These are the references from where I have taken this information, a review article, an extensive systematic analysis, as well as another review article from understanding the impact of delayed diagnosis of misdiagnosis in lupus. Moving on to real world consequences. Now, if you delay, what happens? A missed lupus nephritis will put the patient in end-stage renal disease. End-stage renal disease, in my opinion, is more like a death sentence. You cannot go anywhere, you cannot do anything. Every 3 days, you have to go to the hospital, hook to a machine and stay there till the machine does the job, because your kidneys cannot do it anymore. And missed myositis, again, respiratory failure. You need to walk around with a CPAP, BiPAP or a long-term oxygen. You barely have the energy to go reach your bathroom. Missed systemic sclerosis, similar scenario, plus there is pulmonary hypertension. Missed RA, this was quite significant 2-3 decades ago, and thankfully for the antibodies that we are testing, which a little more often, like rheumatoid factor and anti-CCP, it gets recognized more early and is treated more early. We see very less number of patients who have all kinds of swan neck deformity, ulnar deviation and whatnot because of rheumatoid arthritis. A deformed hand cannot feed its own body. You cannot even hold a morsel of food in your hand, forget about writing, reading, etc. And also they require multiple replacement surgeries. You can replace the knee and hip probably. We have not yet reached the expertise where we're replacing the small joints of the hands. So let us recognize them early and treat them adequately. So, okay, I am telling you to do the antibody testing, but in what context? First, take a very thorough history. For the question for the topic in question, it is joint pain and rash. Should we do autoantibody in all patients? It is more like telling, when your parents are looking for a guy, there is a boy who's 24-year-old, he's an engineer, he makes 1 lakh rupees, do you want to marry him? It is half the information, okay? You need to meet the person, you need to see if your interests match, if the family background is good, you need to live with the person for the rest of your life. So get more information in the form of history. Are there other symptoms? Is there any symptom suggestive of what kind of a rash is it? Joint pain, what kind of a joint pain is it? How long has it been present? Is it involving only one joint, or is it involving many joints or a few joints? And is it there for 6 weeks, 1 year, for how long? Additional symptoms like breathlessness and presence of nodules, etc., or breathlessness can be again pulmonary or cardiac. Go in detail. Ask about everything that the patient can tell you from their birth till now, including their family's history, to narrow down what kind of test you want to do. So get the complete history, do a clinical evaluation, and then only you will be able to narrow down if an autoimmune disease is a possibility or not. Don't do blanket testing for everybody. Now, after having so much of information, it is easy for us to recognize whether autoantibody testing should be done or not. Screen with an ANA if it is required in the clinical scenario. If positive, you will evaluate for ANA profile, do the complements. It will help us differentiate if a CTD is present or not, and whether further evaluation is required or not. It is important to not over-test, but to test wisely. I am not advocating indiscriminate testing, but I am definitely advocating appropriate testing. You have to do structured, indication-based testing in relevant symptom clusters. Now, what are the relevant symptom clusters? So I have divided the symptoms into 3 categories. I'm following the traffic light signal because almost everybody would understand. Green is where you just have to do some clinical examination and there is no need for you to do any antibody testing. And yellow is where Antibody testing is required, but it is not emergent. But just follow up the patient. And it is red, absolutely do, and do a referral immediately. So I spoke about some holiday destinations. The green are the people who are going to the beach. Give them a sunscreen and a hat and you're done. If they're going in the evening, don't bother about that. Yellow are the ones who are going to the rainforest. One raincoat and a little more stuff, done. The red ones are the ones who are going to the trekking. If you don't give them a double jacketed snow coat and fleece and everything, they will freeze to death. Forget about the body, even their soul will freeze to death. So identify who is going to the mountain and test them appropriately. So most important symptoms that require testing are symmetric polyarthritis with swelling, especially if there is features suggestive of active synovitis, malar or a photosensitive rash, prolonged stiffness, early morning stiffness lasting for more than 1 hour, Raynaud's, Zika symptoms, fever, and organ involvement like ILD, renal involvement, neurological involvement. These require urgent testing as well as referral. Vague aches and pains, no need. If there is no swelling, no inflammatory parameters are high, and it is age-related aches and pains, osteoarthritis, don't bother about it. They are going to the beach. Just remember so much. So these are the combinations that you will be testing the antibodies for. Joint pain, rash plus a constitutional symptom. They require testing. Fatigue, arthralgia plus cytopenias. Raynaud's with any kind of skin change, do test. Prolonged fever, multi-system involvement, especially if it is running for a prolonged duration of time, do test. These antibodies have been discussed extensively from morning. This is one of my favorite slides. It encompasses almost all important antibodies. As you can see, most of them overlap. And the overlap doesn't mean that if it is positive, it means both the disease. You are again interpreting it in the context of history as well as clinical examination. Be aware of the specificity and sensitivity of each of the antibody that you are asking for. Something that says 100% or nearly 100%, trust them. Something like anti-Smith is near 100%. If it is positive, do make sure that if the patient doesn't have any symptoms right now, you will follow them up to make sure that you are not missing something. It is specific for lupus. And something with moderate specificity of 90 to 96%, it might not rule out a disease, but will help you rule in the disease. When you are having a clinical context of which could be rheumatoid arthritis, where rheumatoid factor was negative, but anti-CCB turns out to be positive, I would treat the patient. Moving on, so there is evidence of these autoantibodies which help the clinician in diagnosing. These antibodies are not diagnosing, we are diagnosing. And frequently it has been mentioned in international classification criteria. If antibodies didn't have any importance, why are we doing so much of research over the decades? Like ma'am told, every 2-3 years there is a new antibody. It is specific for some of the diseases. So we want to know more about it. We want to collect all the information before we dive into the marriage. So continue to identify your population, whosoever is going trekking, then only do the testing. And autoantibodies are correlated with disease activity. Some of them are specific for organ involvement, the detection and follow-up. These are all a little outside the purview of my talk, so I'm just going to leave it at that. And final aim is to personalize to each patient. It cannot be a blanket statement telling all of you do this and come. Okay, this is personalized testing as well as personalized treatment. There are only guidelines as to what you can use. Nobody says this is the standard of care for all lupus patients. This is the standard of care for all rheumatoid arthritis. We have options of disease modifying agents. We have options of immunosuppressants as well as biologics. So you fit into whatever the patient's requirement are based on your history, clinical examination, antibody testing, and then you will treat. So the choice of antibody testing should be carefully evaluated in the clinical context. Be aware of both the advantages and the limitations of the methods. Like ma'am has discussed about what methods can be falsely positive, falsely negative. Don't blindly test the report that the lab is sending. You're not sure as to how good the lab is. Always talk to the pathologist before, if you do have some concerns, instead of just seeing a paper and deciding whether a patient has lupus or not. Clinical acumen is essential cornerstone for disease diagnosis as well as patient's management. And there was a little talk about how costly they are. Of course, they are all costly. But if you are doing appropriate autoantibody testing, you are saving lakhs of rupees, which the patient will eventually spend in long-term healthcare. Worth doing in Indian scenario, especially most of them are sole bread earners of the family, and if that person gets affected, the family completely will lose income. So would you rather have a family not eat properly because you failed to do an anti-CCP because it costed 2,500? No, please do. Family economy is damaged, country's economy is damaged. So let's see at the big picture. It prevents costly interventions for ILD. Imagine how much they will be spending for a kidney or a replacement surgery of knee because of the disability and other transplantations. So a good review article spoke about actionable solutions for a such scenario, which was recently published. It said whenever we need to create awareness in the community regarding lupus and involving all the stakeholders, including the patients, the primary care physicians, the pathologists, as well as the rheumatologists. Education and training program, which is guided in helping the primary care physicians as well as other healthcare professionals to recognize when autoantibody testing is important. I would like to congratulate Chandre family for picking up such an important and vital topic. So we are not just talking and discussing about it for the sake of science, but we are also doing our bit in educating the masses as to what needs to be done, how autoantibodies or how rheumatologic care per se can make lives better for all patients. And development of validation of local guidelines for early referral, screening if required, identifying the red flags for SLE or implementation of those that are already existing, develop some new digital tools, AI application, other facilities if possible to identify lupus patients soon. Why am I stressing on lupus so much? Because even though in literature, if you take a look, the Western world has far more lupus than us. But if, as you know, we are a country with billions of people, so in the context of a billion, the number is quite high. And most of these are women in reproductive age group who tend to undergo unnecessary treatments, unnecessary delays, and just because somebody didn't recognize well. With that said, I will end my talk with 3 cases. Case 1 is Mrs. Z, a 45-year-old woman from Davangere. She was a teacher, presented with polyarticular pain and facial rash. Initially managed as non-specific with NSAIDs by a physician. Later, she went back to the physician. She had developed DLE, but the person probably didn't correlate and managed with topical applications. 2 years later, she presented with swelling of face, reduced urine output. On evaluation, it showed that she had developed CKD requiring dialysis. On now evaluating the autoantibodies, ANA was positive, anti-dsDNA was positive, revealing a probable lupus nephritis which was lurking all around, but nobody recognized it because they failed to do the test. This has resulted in a debilitating condition which she will have to go through for the rest of her life. An initial autoantibody panel could have enabled prompt immunosuppression at the right time, preventing such long-term implications. Moving on to case 2, Mr. X. He happened to get admitted in the ENT ward. He was a driver. His main complaint was he has a neck abscess. neck abscess and pain in bilateral sternoclavicular joints, which is very unusual. The neck abscess, neck abscess is like quite a big thing. So he has some kind of immunosuppressing disorder going underlying. So they did all the evaluation. He was diabetic and he had early CKD prior. Now it has become full-blown CKD with a creatinine level of 4. His HbA1c was 12. They were trying to, along with hypertension, they were trying to manage it. He was on hemodialysis, and for 2 weeks he received culture-sensitive antibiotics, which the culture had grown Staph aureus, which was resistant to penicillin. So eventually it turned into MRSA. He received almost 4 weeks of antibiotics before he could further move out of the hospital. They asked for a reference to me because one day in the ward, he started developing multiple joint pains. So I went and I took the history. He said, I'm having pain. From when? From today morning. Then, have you had it before? Yes. From when? Since forever I have had. Forever is when I got married. When did you get married? Around the age of 30. So for almost 20 years, he has had joint pains. What did he do? He took NSAIDs. Not by himself, it was prescribed by doctors, orthopedicians, physicians. He had seen almost 7 different healthcare professionals before he developed a neck abscess. None of them had recognized that it was rheumatoid arthritis because they did not do a good clinical examination, history, or test the antibodies. We recognize that he has rheumatoid arthritis with severe osteoporosis and secondary osteoarthritis. But all I could tell him was, you have rheumatoid arthritis. Unfortunately, I cannot do much for you because you already have fried kidneys, you have very high blood sugar, so I can't give you steroid, neither can I give you my DMARDs at full dose. I will try to do something for you which might improve your quality of life. Does that sound like a treatment to you? But was I failing the patient? The whole healthcare system failed him. He went to people for 20 years. If this is the case that happens to be, these are not anecdotal cases, these are real patients that we have seen on a day-to-day basis. Would you be able to live with yourself if you miss the diagnosis of one such patient and his family is accruing loans after loans to take care of the CKD that he is having because he took NSAIDs by himself or with the doctor's prescription? So my last case, this is the most interesting one. Mrs. X, 36-year-old lady coming from Shimoga. She's a homemaker. Very unusually, usually people who have depression, who's a homemaker from a village, don't seek any kind of medical attention. But Shimoga has a good psychiatry hospital, so she was taken there, diagnosed as depression, treated with antidepressants for 10 years by a psychiatrist. And in the meanwhile, she developed skin rashes consistent with DLE, which was generalized, not just focused on the face. And she consulted a dermatologist. While this was happening in the background, she conceived 7 times and went to term 3 times, delivered 3 kids, and had 4 abortions. 2 obstetricians have seen. I guess they have not listened to or studied as much as Dr. Chaitra, but they also failed to recognize. Later, she developed hair loss, which was again treated topically by another dermatologist. By this time, she started developing a photosensitive rash, which was again treated by sunscreens. And she presented with fever, disorientation, progressive disorientation, confusion to our hospital. She was treated by 5 different specialties before coming here. This is the patient. And she's been symptomatic for 15 years before coming to our hospital. This is her antibody profile. So with that, me, you, Dr. Veena, or anybody in good conscience cannot say, I will not do the antibody test for such patients. Choose your patients, do the antibody testing. Thank you.